Assemblymember Eggman. Item number 7. Didn't see Burke or Manshine.
Thank you, Senator.
Good afternoon. This is AB 1194, Mental Health Involuntary Commitment. Good afternoon and welcome.
Thank you very much. I'd like to begin by saying I accept the committee's amendments. And this has to do with the Latterman-Petrus-Short Act, the LPS for short, allows for the involuntary commitment and treatment of an individual with a mental health disorder. The purpose of involuntary commitment is to provide for prompt evaluation and treatment, the protection of the individual and their rights, and to ensure public safety. Unfortunately, the application of involuntary commitment, otherwise known as a 5150, is sometimes across different counties inconsistently applied. Some law enforcement departments and mental health agencies are interpreting the term danger to others or himself or herself to only apply to situations where the individual being evaluated is in immediate danger. In doing mental health work, with people used to say, if there's not a knife hanging out of someone's neck in that moment, then that is not immediate danger. However, Legislative Counsel has determined that the term danger, as used in the Welfare and Institution Code Section 5150, is not limited to that imminent harm. This bill clarifies that danger or risk of harm shall not be limited to imminent or immediate risk or harm to themselves or others, but requires the consideration of the historical course of that person's mental health trajectory. And finally, this bill would require the 5150 custody form to record whether the historical course of a person's mental health was considered. We have witnesses here in support.
Thank you. Please proceed. State your name.
Mr. Chairman, Randall Hager for the California Psychiatric Association. We are the sponsors of this bill. I think Ms. Eggman summed it up really well. We have observed a wide variability in the application of this statute throughout the state. And I think this clarification will serve to prompt earlier evaluations, and I think that's good for patients. And so we would commend it to you for your support.
Thank you. Anyone else in support?
Mr. Chair, members, Tim Madden, representing the California chapter of the American College of Emergency Physicians. And just to reiterate what Ms. Eggman said, for us in the emergency department, the emergency physicians, this clarification will help us in terms of taking into consideration other information that isn't presently available, and we're in strong support.
Judy Boland on behalf of the California Hospital Association in support.
Stuart Thompson, on behalf of the California Medical Association, would just like to thank the author for her work on this important issue, and we're in strong support.
Thank you. Anyone else? Opposition? Comments, questions? Seeing none. You have a question?
Thank you, Mr. Chair. I want to thank you for bringing this forward, and I'm surprised that there is no opposition present. I'm supportive of the objective, but I am aware of the sensitivity around the very strict criteria that is applied. And just for my clarification, say an incident in a community, not at a health facility, a member of a mobile crisis team, crisis intervention team would also be able to access information based on the history of that individual. Is that, do I understand that?
It is my understanding if they would have access to that information in any case, it would be able to use that information in this case.
Does this bill give them access to the information?
This statute clarification that we're proposing changes nothing in terms of access to confidentiality, confidential information.
Right, but I would think to fully utilize the tools in this, kind of implicit would be a needed access potentially to that medical history or prior incidents.
I don't think the history. So, I mean, just from my own experience and perspective, and in my own county, I talked with my DA about how many of the officer-involved shootings had dealt with somebody with mental health issues, and it was 90%. And I think if we look across the state and country, we see people who have acted to themselves or others in a dangerous way. And there has been a history oftentimes of multiple phone calls to law enforcement, to calling people out. So it's not necessarily accessing people's personal records, but being able to look at, oh, we've been called to this house 5 times in the last 5 days.
So it's not necessarily a medical history.
Correct. It's
behavioral history.
Contextual behavioral history.
Yeah, and it is available information. It doesn't put a requirement on anybody to go seeking before they make a determination.
Great, thank you. Again, appreciate your bringing the bill. I'm glad to move it at the appropriate time.
See no further questions. Moved by Senator Monning. Chair's recommending support. Would you like to close?
Just respectfully ask for your aye vote on this, I think, very important issue.
Thank you. Item number 7, AB 1194, do pass as amended to appropriations. Call the members, please.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Hall. Mitchell. Monning. Monning, aye. Nielsen. Pan. Roth. Roth, aye. Wolk.
Currently has 3. We'll place that bill in call.
Thank you very much.
I believe I saw Assemblymember Burke. Item number 5, AB 1129, Emergency Medical Services Data and Information System.
Thank you, Mr. Chair and Senators. AB 1129 helps ensure the consistency and quality of data collection across our network of emergency medical services, or EMS providers, as they transition to medical patient records. A key requirement for any electronic patient record in EMS is its compatibility with both state and federal standards. AB 1129 requires EMS data collection systems to be compatible, but also ensures flexibility so that providers can choose software and hardware packages that best fit their systems, so long as they can work with the local EMS authority's data collection system. For smaller EMS providers or those like air ambulance providers that serve multiple jurisdictions, allowing for that flexibility strikes the right balance between accurate data collection and provider choice. Amendments taken last week removed the opposition from the EMS Administrators Association of California, and I respectfully request an aye vote.
Thank you. Those in support, please state your name.
Johan Klaes, representing the City of Ontario. They are in support of the measure, and they had requested that on line 18 of page 2 of the bill, the words say existing written contract. I understand the author is willing to take that amendment. We support the bill.
Next committee.
I think we're going to have to do that in appropriations.
Yes, we'll be at the next committee.
Assuming there's an agreement, because we
Yes.
can't. I don't
The
think we
next
even,
committee, we already agreed to that.
we don't have it in mock-up here anyway. So.
Yeah.
Okay, please proceed.
Mr. Chairman, Senators, my name is Bob Berry. I'm the Director of Business Development and Government Affairs for Care Ambulance Service, and I'm here representing the Ambulance Association of Orange County. This bill will do 2 very important things. One, it ensures that all EMS providers submit the data to their patient care record data to their local EMS agency in a format that's compatible with Census and NEMSIS, and then being able to be then forwarded on to the state EMS authority. The second thing it does is it provides focus on that data by preventing the mandate where ALEMSA can mandate a particular software or hardware. For companies like mine, where we serve 3 concurrent counties, we would be forced with having 3 duplicative systems, both in hardware and software, and both as a cost that would have to be passed on, as well as training expense to have your EMT population be able to work 3 different softwares. So we urge your passage of the bill.
Chris McKaylee on behalf of the California Ambulance Association, and I thought one of our member companies drew the best analogy. Without this bill, it would be like dictating that all ambulances had to be Ford or Chrysler, a specific one, and obviously that makes no sense whatsoever. Thank you.
Russell Nowak on behalf of the California Fire Chiefs Association, and we're strongly supportive of this bill. Thank you, Mr. Chairman.
Dylan Gibbons with the California Special Districts Association in support.
Anyone else? Opposition? If we can make some room for them, please.
Good afternoon. Anthony Newman with the County of San Bernardino in opposition. In the interest of time, I'm going to turn over our time to Mr. Tom Lynch. Over here, he is the EMS administrator in the Inland Counties Medical Agency.
Good afternoon, Mr. Chair, members. San Bernardino County respectfully opposes AB 1129, which addresses data collection only. It does not address patient care reports in real time, a keystone of patient care in the state and the country. KEMSIS and NEMSIS were designed specifically for retrospective data collection and analysis, not the ability to transmit patient information to hospitals like we do in San Bernardino County. Health information systems such as ours really allows for the ability for downstream patient care practitioners, emergency department physicians, intensivists, et cetera, to see that information in near real time. A switch from allowing a lump sum medical director to establish a system creates a whole host of problems. The health information system is specifically designed to do the patient care data transmission. It significantly jeopardizes patient care if information is not transmitted in real time. KEMSIS NEMSIS often is collected days, if not weeks, after the fact versus essentially at the time of care provision in the field. And this allows EMS personnel who are not independent practitioners to function under the medical direction of medical control or local EMS agencies as part of an organized EMS system. To move away from that can have a significant impact. AB 1129 also jeopardizes the ability to collect uniform data. KEMSIS and NEMSIS have over 500 data elements involved in that, and the additional local EMS data elements can create a whole host of problems, including the ability to map data across the board. It has the potential to cause delays in patient care and significant, again, impacts to patient care. It also has the ability to impact negatively the integration with health information exchange systems. San Bernardino County is actively working with our local HIE to integrate our data in real time with the goal of having the ability not just for the hospitals to see that data real time, but to have those practitioners in the field, EMTs and paramedics, to see that data right away and be able to get information on patient history at the patient's bedside in a hospital, in a patient's home. Multiple papers across the United States speaking to data suggest one uniform data collection platform is the best way to go. In fact, Riverside County and San Bernardino County are making a significant investment of more than $100 million apiece to integrate healthcare systems to take care of Medi-Cal patients in a very effective manner. Again, KEMSIS NEMSIS is a data repository, not a system of patient care. That transfer of care in the field of information would be jeopardized from first responders and fire departments to transport providers and ultimately to the hospitals. The bill speaks to KEMSIS and NEMSIS, and particularly NEMSIS version 3, which has not been fully implemented across the country. In fact, no local EMS systems in the state currently use that. Personally, I have significant experience with data collection systems. When I was the EMS administrator in San Luis Obispo County, implemented the first uniform patient care data collection system in the country, in the state rather, and had significant experience in determining that if we don't do that correctly, we can have significant problems. As you know, San Bernardino County is the largest county in the U.S., has a significant number of providers and hospitals, and that being said, to try to map all of those together will be problematic. ISEMA, the Inland Counties Emergency Medical Agency, houses the state's data repository that was referred to earlier, but that merely, again, is a repository. We believe that we're uniquely qualified to speak to this because of our extensive experience in collecting, managing, transmitting data, and our contracts with the State EMS Authority to manage the data, California Highway Patrol, and we receive data from 52% of local EMS agencies in the state. We've had very positive experience with collecting on uniform data platforms and very negative experience with disparate systems. In fact, ISEMA, based on our negative experiences, has invested over $1 million to get on one uniform platform and have successfully managed to get ambulance providers that are on disparate systems to join ours with very little impact and very little financial impact to them. While we're sympathetic to those costs, our highest priority is to assure the continuity of patient care. Additionally, AB 1129 sets a conflict between the California Code of Regulations and the Health and Safety Code, in that the Code of Regulations empowers the local medical director of an EMS agency to establish the standards for patient care reporting and data collection and evaluation. Again, it has the significant potential ability to negatively impact patient care and undermine existing systems. And the challenges to put all of those systems together have been proven to be insurmountable in the past in the case of San Bernardino County. Therefore, San Bernardino County must continue to oppose AB 1129. However, we would be happy to work with the author's office on two suggested amendments to that bill. One, the latest amendment allowed for contracts in place prior to, and now written contracts prior to January 1 of 2016. We would like to suggest that the bill be amended to include data systems in place before that date, and would also suggest that we work toward a goal of creating one standardized data collection system across the state of California, a goal that the EMS authority has opined would be very beneficial to the state to be on one data collection platform, and we would be happy to work with the author on those changes.
Okay, all the 6 minutes have been used up. The only thing I'd ask is you provide your name and position, please.
Sam Stratton. I am representing the EMS Medical Directors Association of California, MDAC, and MDAC is opposed to 1129.
Thank you very much. With regard to your amendments, we have absolutely nothing up here that we can analyze. We don't have anything to put up in mock-up form. If that's something the author is willing to entertain, that'd have to be at the next committee hearing. I'm not willing to take a position on it at this time. But you're more than willing to have that conversation with the author. Is there any questions from any of the members? Seeing no questions, is there a motion? So moved by Senator Hall. I didn't say a word.
My apologies.
I didn't say a word. She's within striking distance. I'm surprised she didn't go over there to whack you.
I kind of moved that way.
Okay. Chair is recommending a support. Item number 5, AB 1129, do pass to judiciary. Call the members, please.
Hernandez?
I apologize. Would you like to close?
It's okay. I respectfully request and I will.
Hernandez, aye.
Hernandez, aye. Nguyen? Hall? Hall, aye. Mitchell? Monning? Monning, aye. Nielsen? Nielsen, aye. Pan? Roth? Roth, aye. Wolk?
Currently has 5, enough to get out. We're going to place that bill still in call. We have some absent members. I believe Assemblymember Manshine. Do you want us, Assemblymember Brown, to call you, because you're the last on the file, or do we go by file, or do you want us to call you in your office, or you want to just, do you mind waiting, or? We're at item number 6, AB 1147, Manshine. Good afternoon. Please proceed.
Thank you very much, Mr. Chair and members. I want to start off by accepting the amendments on page 7 of the analysis as author's amendments and thank the committee for their hard work on this bill. Under current law, medically fragile children may receive day, health, and respite care services through Medi-Cal at one of 16 licensed pediatric day, health, and respite care facilities. These facilities serve an estimated 300 individuals statewide. Under current laws, children may receive care through these facilities until the child turns 22 years of age. When the program was established first in 1990, most of the medically fragile children were not expected to survive to become adults. However, because of advancements in technology and the quality of care provided, a small number of these children began to approach the ages of 21 and 22. When the child reaches the age of 22, it forces families to make difficult decisions about how to provide the same type of care and support their loved one has received at a day, health, and respite care facility. Unfortunately, services simply do not exist in the current system for a medically fragile person over the age of 22. AB 1147 would permit medically fragile adults to remain at their current facility in a separate transitional care unit until they reach a mental capacity of 18 years old. It's revenue neutral by ensuring these medically fragile individuals stay in their community-oriented facility and not be transitioned into a more costly state-run institution or in-home care. The sponsors have been working closely with the Department of Health Care Services and other stakeholders, and there is no known opposition to this bill. Here to speak in support of this bill is Peter Kellison, representing Together We Grow.
Thank you. Let me just remind you that there is support on both sides. There is no opposition. If we can make it kind of brief, it'd be very much appreciated. Please proceed.
Peter Kellison on behalf of the sponsors, Together We Grow. This is a rather lengthy bill and a lengthy analysis for a very simple but very important issue, which is to allow individuals to remain where they've been spending their time for most of their life. Here to answer any questions.
Thank you.
Daniel Savino, Association of Regional Center Agencies. The 21 nonprofit regional centers provide service coordination for over 280,000 individuals with developmental disabilities. One of their tasks is quality assurance and oversight. I've had some extraordinarily productive discussions with the sponsors and the author's office. Very proud to be in support of this bill. It provides a worthy extension of an excellent service to a small but very important group of people.
Thank you.
Bernadette Ariano on behalf of the California Children's Hospital Association, carrying forward our support from the last House, and thank you very much.
Thank you very much. Opposition? Questions? Comments? Seeing no questions, comments, motion by Senator Roth. Chair is recommending support. Would you like to close?
Thank you, Mr. Chair. Members respectfully request an aye vote.
Item number 6, AB 1147, do pass as amended to appropriations. Chairs are recommending the support. Call the members.
Hurry. Yeah.
Hernandez?
Aye.
Hernandez, aye. Nguyen? Hall? Hall, aye. Mitchell? Monning? Monning, aye. Nielsen? Nielsen, aye. Pan? Roth? Roth, aye. Wolk? 5.
Currently has 5, enough to get out. We're going to still put on a call where you have a second item, number 8, AB 1211, healthcare facilities, congregate living health facilities. My understanding, this also has support on both sides. No opposition. Please proceed.
Thank you very much. And in light of that direction from the chair, thank you for letting me present. AB 1211 modernizes the limit on the number of beds allowed in a congregate living health facility to help meet medical demand while still maintaining the residential settings that they must maintain. And I respectfully request an aye vote.
Thank you very much. Support, please. Support?
Yep. Mr. Chairman, I'm Jim Ashby with Care Meridian, sponsor of the bill. We've been operating under this licensure for 25 years, and this amendment to the bill, or the bill itself, will take the limit from 12 to 18, which allows us to serve more of our patients, give us more access. So we appreciate your support. I have with me a family member as well of one of our patients.
Hi, I'm Erin Nichols. My husband has a traumatic brain injury sustained in Iraq as a Marine. I love Care Meridian for the high level of care he's able to receive, but in a home-like environment, which makes me and other family members feel comfortable, not just visiting, but staying and spending time with our loved one. And we can watch TV and congregate with each other and form social relationships and bonds with patient to patient and also patients' families with each other. And the staff not only takes care of the patients, but they really care for the patients. And we've experienced that above and beyond relationship many times. When I told my husband what I was coming here to do today, he asked if they needed a patient to speak to it. And so you have his endorsement as well.
Thank you very much. Opposition? Any questions? Seeing no questions, there's a motion by Senator Roth. Chair is recommending support. Would you like to close?
Thank you, Mr. Chair, and members respectfully request an aye vote.
Thank you. It's item number 8, AB 1211, do pass to appropriations. Call the members, please.
Hernandez?
Aye.
Hernandez, aye. Nguyen? Hall?
Aye.
Hall, aye. Mitchell? Monning? Aye. Monning, aye. Nielsen? Aye. Nielsen, aye. Pan? Roth? Aye. Roth, aye. Wolk? 5.
Currently has 5, enough to get out. We're going to still place that bill in call.